ionization, crystal matrix, vaporize, flight time of molecules bombarded by lasers. I mean, freaking lasers. You might think I'm talking about some 1980s sci-fi movie. But nope, this is actually how our sponsor for the pathology series will be doing your microbiology samples. It's called Malditoff, which sounds a bit like something you set on fire and throw at a building during a revolution, and not the pinnacle of diagnostic microbiology, right? There's a video that I'll link to in the show notes, which is just too awesome in itself. But what's even better is the first comment, where one user says, "I wish the machine actually made those pew pew sounds." In all seriousness, if this is the standard of high quality, high tech diagnostics that SVS, which, if you've been listening, you'll know by now to be the SVS Pathology Network, composed of Vetnostics in New South Wales, QML in Queensland, TML Vetnostics in Tasmania, ASAP in Victoria, and VetPath in WA. If this is what they're doing, I reckon your results are still in safe hands. You knew they were good. But this is some next level stuff. It beats the crap out of smearing some gunk out on an agar dish and chucking it in the incubator, or the stinkubator like we used to call it at a previous job of mine, and then sitting around for 2 days while you have to wait for it to grow, or not to grow, and then repeating the process again to isolate the bug from all of the other gunk growing on there, and then seeing if you can kill it with those little antibiotic infused discs. Not with this stuff though. How Malditoff, which is short for matrix assisted laser desorption ionization time of flight mass spectrometer. How it works is that your microorganism sample gets fixed on a matrix, and then the little bastards get nuked by a laser, which totally vaporizes it into its basic molecules. So long and then the molecules get sucked up in a vacuum tube onto a sensor. But of course, the fat kid molecules will get there long after, like several microseconds later, than the whippity little lightweight ones. And the machine is smart enough to calculate who they've just vaporized by identifying the temporal pattern of the molecules hitting the sensors. Now, if you're getting confused, don't worry, I am too. But did you hear that I said lasers? I swear the next time I'm sick, I'm sending my own sample for Malditoff just to have the joy of knowing that some of the things making me sick are going to get vaporized. Now, because this process only needs a tiny sample to identify unknown molecules, it means that the guys at SVS can eliminate the purification stage where you have to re-smear those samples to isolate the different bugs. What all of this means is faster results, better decisions for your patients, and happier clients. Our guest for this episode is SVS pathologist Dr. Kristen T, who admits that she has a little bit of a soft spot for all things microbiology. And our topic is urine. For such a seemingly simple sample, there's actually a lot of uncertainty around much of the sample handling and interpretation. It's also the one bit of lab work where having a solid understanding of how to do some of the testing in-house can make a big difference to the reliability of your results, which is why this is such an important episode. Now, I know you've had some arguments, or at least a heated debate at some point of your career about at least a few of the questions we answer in this episode. Like fridge versus non-fridge. How old is too old for a urine sample? How long after starting antibiotics can you still culture? Is it worth culturing a free flow sample? Can you trust your dipsticks? Can I trust AI? Now that's maybe a broader philosophical question, but we mean specifically in the context of urinalysis. I also suspect that you'll learn a few things that you didn't even know you should know. So take that pot of pee out of your pocket, sit back and enjoy. Dr. Kristen T. Kristen, welcome to the Vet World.
Thank you. Thanks for having me.
Let's talk about pee.
We have a rule in our hospital that I think I walk around with a whipping the vets at, and that's with every biochem needs a urinalysis.
So we start at the very, very basics. You get your urine and we start with a dipstick. Dipstick, first of all, I never know how much to trust them. We were taught, because we all used the human dipsticks, and we were taught that most of it you should take with a grain of salt because it's made for humans and some of the results don't translate well to animals. Has that changed?
You jumped ahead a little bit.
Oh.
How you get it and the circumstances that you're getting it from. I mean, evaluating a urine that you get out of a kitty litter tray versus a urine that you've done by cystocentesis can make a difference, as well as how soon was it processed. Did the owner collect it at home? Did you collect it in the clinic and you're doing it straight away? Those kind of things can actually affect the dipstick. So if the owner drops it in and it's been refrigerated, it needs to warm up. Otherwise, you can get false results on the dipstick. So I don't think much has changed for dipsticks, except, as you're probably aware, there's now automated dipstick readers. So you don't have to decide what color that pH is. But the accuracy of those, is that any better than the human eye? There's some controversy about that. If you're trying to make things quicker, you can just automate things, then, doing the dipstick with those automated readers can be helpful. But whereas with every test that you do, you need to know what the pros and cons are, what they actually mean in the circumstances that you collect them. So with the dipstick, most people tend to look at the pH quite commonly, glucose, blood. The things that you shouldn't pay attention to would be things like the leukocytes, because that tests just one part of the leukocytes still. Ketones, you can look at those, and protein, but again, collection method can play a role in what you get. So, are you doing ketones in an absolutely normal dog? What do you do if it's positive? Mm-hmm. How do you interpret that? It's a normal dog, there's no glucose, and you've got positive ketones. So knowing what can affect each test is as important as doing the test, I guess, to some extent. And if you go back with the glucose, reading that, it needs to be, is the glucose going to be positive because that cat is absolutely freaked out in the exam room? Or a nice benign basset hound that you've gotten urine from that's got a 3+ glucose? And also, as you say, with the biochem, interpreting it in context with the biochem. I can't tell you how many times I look at urine, and really the urine specific gravity is quite important. Certainly interpreting azotemia, just looking at a biochem, if the only thing you can get is a urine specific gravity, it might make a difference in understanding some of those blood work results.
Oh, I totally 100% agree there. And sometimes urine has the answer, like there's a fever of unknown origin, and then you get, what's the missing link, or what's the missing test, or which one haven't you done? Urine, because dog didn't wee, or because I don't like doing cystos or something like that. And then there you go, you get some pyuria or something like that. Like sometimes the urine could be the key, I think.
Yeah, exactly. But pyuria in a female dog that you've got a voided sample from is completely different from pyuria in a dog you've done a cysto on.
So where are we going to take this? Are we going to go back to a bit of sampling things, or?
Well, I think there's some situations where that chihuahua is going to bite your hand off and it pees on the table.
Yeah.
Can you use that urine?
I use it for USG.
Yeah, or you can use the urine, but as you say, with a grain of salt, your interpretation is different. And if you can do an ultrasound guided cysto, absolutely fantastic. Obviously, most of the guidelines for testing recommend a cysto for most things, but there are situations, as we all encounter, where it's just not possible.
You said just then, like voided samples, and then you mentioned there for females, and if they have, you see bacteria there, then it doesn't rule in a UTI, basically. Like doesn't mean that there's an infection higher up. That was my interpretation of that. But what other things with voided samples should you be wary of?
Well, obviously, with voided samples, things that pass through the distal urinary tract can create contamination. Protein, blood, any of those things where you might have contamination from the urethra, the mucous membranes of the penis or the vagina. There's a lot of lovely flora that live in those areas that we consider pathogens that may not necessarily be pathogenic. And there are cases where you have people who monitor bladder infections with voided samples. They have pyuria and they have a multi-drug resistant Pseudomonas. However, when they've done a cysto, they've got no pyuria and no bacteria. So it's really quite important to understand what's the normal flora of the prepuce and the vagina. Just because you get it in pure growth doesn't necessarily mean it's something. It means that is a very dominant bacteria,
Especially, okay, I'm sure everyone can visualize a prepuce of a dog with the discharge that comes out of that, and then you get a urine sample.
Yeah, that ain't sterile.
Yeah, but you could alleviate some things by cleaning it before you get that wee. Same with the vagina. I mean, humans don't, on a routine basis, don't get sterile cystocentesis from patients. So there are things you could do to minimize it by cleaning those areas and, pulling back the prepuce when you get a sample, a voided sample, or parting the vulva to some extent, or cleaning that area prior to urination. That might give you less chance of contamination.
Okay,
People often ask, should I culture it? Should I culture voided urine? Sure, you can culture it, but it always needs to be interpreted in context with your clinical signs and how you collect it.
Can I jump back a few steps? At the beginning, right at the beginning, you mentioned how old is the sample? Has it been refrigerated, all that sort of stuff?
Yeah.
Did you say you need to warm it up before you look at it if it has been refrigerated?
Sure do. So obviously, in the ideal world, you collect that sample by a cystocentesis, you hand it to your nurse, or you do it, or your intern if you have one, and they go back and they run that urinalysis straight away. They do the dipstick, they spin it down, they make all the slides, they look for crystals, they look at the cytology, all done within 10 minutes. That's not the reality of general practice. So you get the urine and you can leave it on the countertop, but keeping in mind that if you've got bacteria in there and you want to do a quantitative culture, that those bacteria will multiply because they love it. So you can get them doubling in numbers for every half hour it sits on the bench. If, however, and this is an important point, if you want to know any bacteria there, so qualitative, you just want to know what's there and what the sensitivity is, then you can leave it on the bench. The bonus of that is that any fastidious organisms that don't like cold will not be stressed. But the other problem is that bacteria that might be dominant may overgrow anything else that's in there. So most people will label it properly, of course, and put it in the fridge so that when they get to a quiet moment, they can get their lab tech or whoever to process that. So obviously doing the dipstick, and they really do recommend that you do those things quite quickly, but ideally within 2 to 6 hours, it should be processed. So if it's put in the fridge, however, you need to warm it up to room temperature, because refrigeration can give you false positives on your dipstick, and it can also create crystals that weren't there when you collected it. So calcium oxalate and struvite crystals can precipitate in cold urine. So you warm it up, get it at temperature before you do any testing on it.
Just leave it out till it warms up, or in a water bath? You're not going to microwave it for a second.
You could, but I think the best way to do it is to warm it up to room temperature in a normal fashion. Depending on what you collect it in, you could put it in a pocket of your shirt, or you could have someone slip it in just under their shirt and in your back pocket, as long as you don't forget it. And that will warm it up quicker without shocking it. There's ways to do it, but probably not a water bath, not in the sink, and probably not in the microwave.
Yeah.
Okay, cool.
Okay.
I didn't know about that, the warming it. That's because a lot of it is, especially the ones that come from home that clients bring in, will be refrigerated.
And ideally, you want them to drop that urine off as soon as they possibly can. So you really don't want them to collect it that night, leave it in the fridge for 12 hours and get it to you in the morning. Because by the chaos of the morning, somebody's not going to process that till lunchtime. That's an 18-hour-old sample.
Yeah, I suppose then also if you get a morning voided sample, then you get the patient's most concentrated urine as well.
Ideally, yeah.
So that might be helpful in terms of interpreting or evaluating the kidney function, I suppose.
Yeah.
Then the storage, we've touched on this with Brett in the previous episode, but he said we should ask a microbiologist. So again, if I'm going to send it off for culture, I want to know if there's bacteria in there. And then I put it in the fridge, which I never understand why should it be in the fridge. I feel like... But is that what you said before? Because it's quantitative, because it's going to slow down excessive growth.
For some people, if they're trying to decide whether that bacteria is relevant, they'll want to know how many colony forming units were there. They want a qualitative, they want to know so they can decide whether they're significant or not.
Okay.
I would say on the balance for most clinical practitioners, they want to know, is there anything there? because they suspect that this dog is, or a cat is symptomatic. The owner wants to treat it with something, and they've got obvious, they've done a urinalysis, or you send it in for urinalysis, and there's obviously pyuria, and the things that you would say this animal has a UTI. And then the most disappointing thing sometimes is to come back with a no growth. But that happens. But when you come back with a growth, people want to know light growth, moderate growth, heavy growth, and pure culture or not. So if you're looking at something that you've been treating and there's something there and you just want to know any bugs, and you can leave it on the bench.
Gotcha.
But your interpretation needs to be, sit on the bench for 12 hours. So keep that in the back of your mind.
It just made my whole the whole decision-making process a bit harder for me. Just like, do I want to know what's in there for real? Or do I want to know if there's anything's in there? So,
It also depends on your clinical case. Is this the first time you've ever had a UTI? Is it a current UTI? Is it associated with something else? Is this a diabetic or a hyper A dog that's got a UTI?
So if you knew that, okay, so let's say if you knew that there was bacteria there and you were treating for a while and you wanted to know whether things were getting better or not, then you'd use a refrigerated sample because it...
Personally, I wouldn't.
Okay.
The reason is that you've given me just a completely different scenario.
Sure.
You've got a patient that you're treating and you want to know, is it working? Correct?
Okay. Yeah.
So if you want to know if it's working, maybe you want those bacteria to triple, because that means there's a single organism in there.
Okay, cool. Okay, yeah.
And you have a better chance of finding out if it's there and a sensitivity to it.
Okay, gotcha. So we want them to...
If you're on a fishing expedition, you're just doing a urinalysis as part of a complete workup.
Yeah.
Your urinalysis is fairly okay and it comes back with an enterococcus. That's a whole different situation where you've got an animal who's possibly not symptomatic and you've got bacteriuria.
Yeah.
Subclinical bacteriuria. So there's a whole set of guidelines that have been published in 2019 by an infectious disease group on UTIs. It is brilliant. It's a good read and it's good to just refer to. It has a list of all of the antibiotics and how to interpret your sensitivities and MIC levels and stuff like that.
Wow.
That get really good levels in the urine, things that get better levels in the prostate. It's quite a good reference article to have when it comes to, simple UTIs versus recurrent versus prostatitis versus pyelonephritis versus, those situations that we often encounter.
Yeah.
We'll get a link to that somehow.
Yeah, I've got it on those notes and I'll send it to you. It's the International Society for Companion Animal Infectious Disease Guidelines.
Awesome. I'll put that in show notes for sure.
Yeah, and it lists all of the antibiotics that we give sensitivity levels to that people, as you probably are well known in clinical practice, we're coming across multi-drug resistant bacteria all of the time. And so it gives you a nice little rundown of all of these types of things as they apply to the urinary tract.
Cool. That sounds awesome.
Now, I feel like we're talking about culture. We sort of strayed into the culture.
It's my area. I know.
We may have to backtrack back to the in-house analysis, but let's ask questions about culture then. How long after starting an antibiotic does culture become affected by it? So let's say an animal for some reason has a jab of Clavulox in hospital, and then an hour or two later you go, oh shit, I should actually be doing urine culture.
Yeah, not that quick. Not
that quick?
24 hours, maybe.
Oh, okay, cool.
At times.
Okay,
Depends
cool.
where you gave the jab, what the drug is, and what the situation is. So if you are able to take the sample after the animal started on antibiotics, or you've, sedated it for something else and you've given it antibiotics and now you can take all your samples, that's fine. If you've got an animal that's, you're worried about systemic disease or pyelonephritis, then you'll be taking blood cultures and cysto and doing all sorts of stuff like that and giving antibiotics at the same time or prior to that, who knows? So you've got about 12 to 24 hours leeway on that. But the other thing is that if the bacteria that you culture ultimately is or isn't sensitive to that antibiotic, that will also tell you something as well. So if you've given the antibiotic, it's sensitive to it, but it's still growing, that means maybe you should continue that particular antibiotic for the appropriate amount of time before you determine it's not working or whatever, because you gave the antibiotic 12 hours, but you've taken the urine. So you may not have killed everything.
Is that IV and subcut? It doesn't matter. Like,
it depends on the antibiotic and it depends on the levels that they get in the urine and how quickly they reach those. So it might reach therapeutic levels in the urine within, 2 to 5 hours. Does that necessarily mean it's actually going to get to the bacteria that's in the urine? Are you going to kill off all of them?
This is a really good conversation, because this is like a conundrum that we have. It's kind of like, we need all the samples before we give IVs, but then the dog's looking like it's dying of sepsis, and then kind of like every hour that you delay giving antibiotics, the more likely the patient's going to die. So yeah.
Yeah, don't. And if something grows, then you'll know maybe that's something else in there that you aren't treating with that antibiotic. It's quite a good scenario that, some people recommend culturing while you're under treatment to see how it's going. And what happens when you get a couple of different results? What should you assume from those results while they're on antibacterial treatment?
I think I was taught so before, and then start, then maybe adjust when you get your results. And then it's like every, it was 2 weeks. And then 2 weeks after you get a negative or something like that. Like, that's the top of my head.
Yeah, I guess that would be in a really just a simple, uncomplicated UTI, and you've got resolution. Do you need to follow up and keep going? Maybe not. Maybe you don't need to do that 2 weeks, 6 week, If you've got a recurrent infection, that's a whole different ballgame as far as what you're doing, because generally after 2 weeks, sometimes as early as 5 days, you get a recurrence of the symptoms. And frustratingly, you're growing the same bug with the same sensitivity pattern that you should have gotten the first time. And usually when you get that sort of situation, maybe something else going on, or you're not getting through to that biofilm, which is really what people need to start considering. That B word in a lot of bacterial infections, no matter the area. Often bacteria make these biofilms that are quite protective, and you can get mixed organisms in these biofilms, incredibly frustrating, like the ear. So in urine, the most difficult biofilm to try and penetrate through is the E. coli, which it's the number one bacteria isolated from urine cultures. And these E. coli can make not only extracellular biofilms on the surface of the bladder, but also intracellular biofilms within the cells. So they've got multiple layers of protection that you're going to have to try to figure out if this is the case. And often if you have multiple UTIs within a short time of each other and it's an E. coli, that's probably what you need to start thinking about. Now, there's a lot of research out there. All of the current research these days, especially for humans, is what can we do to dissipate or get through that biofilm without actually hurting the mucous membrane, the mucus layer of the GI system of the bladder. What can make the antibiotics that we use more effective in getting through those biofilms and actually becoming more effective in eliminating the infections? And that's a problem in the bladder.
So just to be clear, the biofilm's not just around the bacteria. They sit on the bladder wall and actually cover themselves with a film,
mucus, yeah,
with a mucus to say, so the antibiotic can't even get near them because it can't get through the biofilm.
That's right.
So what's the answer?
Oh, I was about to say, is there you go in there?
Well, it depends on the bacteria. There's no one answer for every situation. And it just depends on the bacteria. And the more distant the bacteria, probably the less biofilm. So the more susceptible your bacteria is, especially E. coli, the more likely it is to be a biofilm producer.
Really? So your results say, yeah, I'm easy to kill.
Haven't you gotten those before? Susceptible to everything, and that's what the dog was on. And then as it goes off, it's back again.
So the bacteria says, yeah, don't worry, you can kill me. Throw those drugs at me, I'm fine. And then it says, You're not going to touch me with
And
it.
you've ruled out your underlying causes like Cushing's or diabetes or whatever, or some kind of immunosuppressive
Obesity.
disease. And then, and then you've got these little bastards with biofilms. Now, I still want to know, what do you do then?
There's a lot of things out there that can help. So you have certain antibiotics that are very good at penetrating biofilms. So beta-lactams aren't, penicillins aren't, but they're actually a really good drug for certain types of bacteria like Enterococci. But they just don't penetrate biofilms as well as, say, fluoroquinolones, who go right to the problem. But we don't want everybody pulling out the loans right out of their pocket, do we? They may not need it. So it needs to be reserved for the situations that are chronic and problematic and symptomatic. So if you've got that situation with a biofilm, there are some things like a Pseudomonas where you can use two antibiotics together, one to sort of dissipate the biofilm and one to actually get through it and kill the bacteria. And there's a lot of research on that in humans for these multi-drug resistant bacteria. And but in the matter, you can imagine how hard it is to get a Pseudomonas. I think I would rather tackle that though than one of these E. coli's that are so sensitive and living intracellularly and just keep recurrently happening.
Wow. So this information is part of that guide or in the guide about the biofilm?
Some of it is, yeah. Some of it is, but these are guides and not, rules. So they can't say, okay, specifically in this case, this bacteria with this circumstance, this is how you treat it. That's why you develop a relationship with an internal medicine specialist or a microbiologist or someone who you say to them, I've got this case, this situation. What do you think?
This is where you phone your pathologist.
the question I always have with these like consensus statements, which come out with kind of this antibiotic for this particular thing, and it's research like microbiologists from around the world or something like that. Is there regional differences, or can you take one of those consensus statements and then go, yeah, that applies to us? Or is there big differences between US and Australia with those?
Well, yeah, there are differences. There are certainly differences between the US and Australia, and certainly differences even in how you get reactions to drugs from US and Australia. But what's really good about this consensus statement that I was speaking about is it actually recommends that you as an individual practitioner in your hospital come up with your own antibiogram to figure out what's happening in your area. So to have an example is, what I mean is that just take all the urines that you do by cystocentesis and send off for culture. Whatever you got back, E. coli, Enterococcus, whatever, just collate that information into how sensitive they were. And then what you can see is that, wow, 60% of the E. coli's that I get back are actually sensitive to penicillin or amoxicillin.
And that's your first line.
I'd say, none of them are sensitive to amoxicillin, but all of them have been sensitive to clavulox. So what drug are you going to pick first on that first time? And if you do in-house urinalysis and you do see rods or cocci, even if you go that basic, which one are you going to pull out? If it's rods, then your chances are 60% that it's going to be an E. coli. Cocci, then it could be an Enterococcus or a staph. So knowing what you've gotten in your area, that doesn't mean you don't do culture. That just means that when you have to put the animal on something first before you get that culture back, or if it's the first time, you know what you can pull out that have the best chance of working. And that is strictly for your hospital in your area. I'll tell you, regionally, we've looked at things in Victoria versus things in Sydney. And in one group, in one area, the E. coli were fairly sensitive to amoxicillin. So that'll be the first thing you pull out. But they were not sensitive to amoxicillin in another. It was clavulox.
That's really interesting.
I didn't think that the biomes would be that regional. So
no, but I guess it's about what they've been treated with before, what their humans have been treated with before. There's a lot of things that come into play in your area. If you have a low socioeconomic group where there's not a lot of preventative medicine. And, that happens. Or if you have a rural area, it can make a difference.
Or if you're a clinic that's been there for a long time, probably the local biome
It's created by you.
It's partially created by you over the last couple of decades.
Yeah, definitely.
Or at least influenced. What about the ones you mentioned earlier where you do your in-house urinalysis and you see pyuria and then you send it off and then you get back up, nothing grew? What does that mean? Why does that happen? Is that something I did wrong in the clinic?
Well, there's a couple of different reasons. So if you've done your analysis and then you do your sediment, so you do a wet prep, and ideally you've done your one stain with methylene blue and the other no stain at all, drop your condenser down and see what you see. Sometimes people misinterpret what they see as bacteria. So the other recommendation is to make a dry prep of that sediment as well. Now, the reason this can be incredibly helpful is once you make that, you have frozen everything in time. So if you need to send that to the lab to have someone else review it, you can. But the best thing is that what you might not exactly recognize as cockeye, and it looks like Brownian movement or whatever you might think you see under the microscope with the wet prep, if you stain it with a dipstick, then you might definitely see that that's cockeye. I can't miss that. That's yeast, that's rods. So when you use your sediment, my recommendation is to use 4 drops. You can use 4 slides, or you can use 1 for the wet prep with the little cover slips and do 1 stain, 1 unstain, and then 2 dry ones where you can put them on the slide and you can just sort of slide them together to make 2, or you can do 2 separate ones, but they need to be smeared out gently, air dry them, and then stain 1 to look yourself and keep 1 unstained in case you want to do a gram stain or send it to the lab for a second opinion. So it's a really quick thing. You've got the sediment made. You might as well just do it. What you might mistake as cockeye might not necessarily be that. And the other problem is that you can get anaerobic cockeye that don't grow well in aerobic conditions of being shipped to the lab.
Oh, in a container with air and stuff like that and stuff.
Exactly. So that can happen too. And
that's what happens with all my samples probably.
They could die. So as you say, they're very sensitive and so they're not growing.
So just going back, Brownian movement, that's that little, when you're looking down the microscope, it's like little buzzy things.
Yeah. Okay. But keep in mind though, unless you're trained to do it, unless you train another nurse or technician who does it all the time, some people aren't going to really know what they're looking at. And so they're just going to think any round things under the scope are cockeye. It must be bacteria.
Yeah. Any tips there? Because that can be challenging. I feel like I've been looking at urine for 20 years and we spend a lot of time at our uni looking at.
Yeah.
But I still sometimes struggle. Sometimes you still look at them and go, are you a bacteria or are you just
And how
gunk?
often do you change your stain? So what you might see is, oh God, it's full of whatever, but you haven't changed that stain in, a month or more.
Yeah.
So how do you know that's real? So it's a matter of evaluating your own lab practices as well.
Methylene blue, what does it do? Does it add contrast, highlights?
Well, it does stain some things so that you can see, and I think what you would say, it gives it contrast. But if you don't have it, you don't need it, as long as you drop the condenser on your microscope.
Yes.
So that gives you the most contrast, really, so you can pick out things. And if you can use methylene blue, that's fine. What they're hoping is it might stain some of the bacteria. Lipid obviously won't take up stain because it will be hydrophobic. So it might help differentiate some of those things that might be a little bit, if you're not great at identifying maybe what some small leukocytes look like versus a red cell and things like that. It might give you some degree of detail that differentiates between things under the microscope, but you don't have to have it. But it can help. It's great to look at them side by side. That's why putting 1 drop under a cover without stain and 1 with stain could be helpful.
And you're looking at the times 40 or the times 100 or?
Always need to scan first at 4x because you want to look for casts. Doing a urinalysis in-house during your own cytology is the best chance of looking for a cast. in transit, they'll break up, they'll fall apart. Casts aren't common, but you'd be the best one to look at it. And also just picking up crystals. It's hard to know whether it's real when they're in transit, refrigerated, everything else, because like I said, crystals can precipitate, they form, they dissolve. So looking for crystals right out of the animal is the best.
And just to clarify, why not just go straight to Diffquick? Why do we have to look at the unstained or the plus or minus the methylene blue? What's the advantage?
Well, you can, but then again, also Diffquick can distort things as well. And Diffquick are going to be better for cellular elements, especially if you're concerned about neoplasia or dysplasia or something like that. It's going to be better for the things that we would normally look at, not necessarily crystals, or it might alter some of the aspects of the urine that, probably you might misinterpret. So you can do that, but again, more information is best. The quickest way to evaluate it is going to be without the stain in a wet mount. If you ask for cytology when you send it away, all of those cells will fall apart in transit. They just can't help it, especially if there's bacteria there. And it's probably really frustrating for people to send away a urinalysis for cytology and we just say, look, the cells are too degenerate. I'm sorry, I can't tell you anything. So if you make that sediment smear there, then that's ideal. Otherwise, I recommend people actually send in an aliquot of the urine in EDTA, in a purple top tube, because bacteria don't grow in the presence of EDTA. It does preserve cells. When you send in peritoneal fluid or abdominal fluid, we always ask that you send it in a purple top tube so we can do a cell count and do appropriate cytology. But we don't culture from that because EDTA will prevent bacterial growth rather than aid it.
Wow, that's the first time I've ever heard of that.
Now, here's another first too. If you want to know exactly, if you take a cysto and you're not concerned about quantitative numbers, put it in a blood culture bottle.
Okay.
That's a great media for enhancement. It works for both anaerobic and aerobic. And if anything's going to grow, it's going to grow in a blood culture bottle.
So that's like, if there's a UTI there, if anything is there in there.
You want to know if there's anything in there, because you won't be able to say, oh, it's really low numbers, because you've enhanced it. So there'll be times when we'll ask for enhancement because, it's a situation where there is going to be bacteria there, and we just got to make sure there's none.
So let's recap. If I'm hunting bacteria, then, as you say, consider a culture bottle. Don't necessarily put it in the fridge and send it off to you guys. If I'm concerned about cells, so if there's cytology, if I see something and I go, what the hell is that? Then consider sending a sample in EDTA and make a fresh smear and send your smear along with the sample. Yep. Does that make sense?
Or ideally, if you don't have enough urine, because, we don't get huge pots of it, just send the smear.
Yeah. Okay.
I'm a big fan of blow drying things because of an emergency. I'm like, I can't wait for it. How much does that kill things with the urine? What does it do?
It can certainly alter things. I mean, what does it do to your hair when you're blowing it dry?
Makes it gorgeous.
Keep in mind that, you're blow drying it. So you're putting that heat really close to cells. It's not a gradual thing. You're like fry. And so it can distort things. It can be really quite annoying. If you're that impatient, get a slide warmer and just put it on there, and that will gradually warm it up.
I've seen people put them on top of coffee machines.
Yeah. Anything that has a little bit of warmth to it will speed it up without hurting it.
If you have an Apple Watch and you're monitoring your movement or any of the go with your watch hand, because that adds a heap of points to your
You got your steps in.
Your steps.
I do 2 cytologies today.
Here's my tip for the day.
Yeah.
Is there anything more there? Because I've learned a lot from. I almost feel like we could just wrap it up.
Well, you did want to know about the AI machines, didn't you?
Yes, that's the next question. Are they? That's it. Is there evidence? I'm old school again. I love looking at my own stuff, and then this machine arrived at my old job. I was like, I don't trust this thing to give me results. Are they? What are they like? Do we know?
Well, there've been debates on them. There's been discussions in groups versus these AI machines and the pros and the cons and things like that. And if you're very time poor, again, it's just like doing your own samples. You've got to know what the circumstances are and what their drawbacks and everything else. So with these machines, if you think about what you do in the clinic, basically now, you need dipstick, slides, stain, maybe, that's it. These machines, there's going to be consumables. On the other hand, you can train anybody to do it. You know, you can train somebody to set it up, but in the end, both of them require a degree of knowledge about things because they will show you photos of the sediment depending on what you do. And you need to judge whether that's right or not. There's papers out there that talk about it. Is it good for casts? Well, you know, do you really see that many? Is that what you're interested in? Or are you really just interested in the crystals and the sediment? Yeah. So yeah, there's some degree of if it's negative, then that's all. You can be comfortable that it's negative. But if it's positive, you might get false positives and things like that for crystals. Most of them only look for the two main crystals, which are calcium oxalate and struvite crystals. Okay. Most for casts, and either they're hyaline casts or non-hyaline casts.
Oh, wow.
They're not giving you the amount of detail. If that's what you want, you can hand a nice report to the owner with pretty pictures on it, and that might go towards your marketing. It just depends on what you want out of your machines, but it's about time.
I'd be the kind of guy that if I saw something on the sediment images, I go get the slide and I go and look at it myself. It's like on the hematology machine, it says these kind of things. I want to see it myself. So do like, I don't know if I'd ever.
So you should. So yeah, they both work to some degree, and they make a difference for people who are only interested in ruling out the common things, which is what they're made for. But there is a degree of, sometimes they miss the uncommon things, and that's actually the key to the diagnosis. So you need to always look at the photos of the sediment. And, if you want to look at 70 photos,
that would be me. Would it be like a good, like, if you see a clear, if the machine gets a clear, then it's a clear, as opposed to if the machine gets a positive, then I would still go do the sediment, but it could be like a rule out, like you put it through the machine gets all clear, it doesn't see anything, then you kind of know no sediment. Like, it's a very sensitive test.
Yeah, it's very specific. It's very not specific.
Okay.
So, yeah, and I always have to look up the meaning of those, but yes, if it's negative, you can be comfortable in it that it's negative. If it's positive, then
that could save a lot of time, actually. Should we dig into casts for a little bit? Because I'm a big cast kind of dude, in a sense that, like, once you know what they look like, in a way, then you kind of see them. But some people don't. Yeah. So like for me, they're like a tubulous, like you shouldn't have a tubulous things, like shaped things in there. And if you shake up your sample too much, it all gets broken up. But once I saw a cast once, then I knew then that's what a cast looked like. It's like boom. I can see them now. So, but what kind of microscope? So you got the ×4, ×10, and then you got the ×40, ×100.
4,
times
10,
4.
40, 100. Yeah. And so you can, ideally, you want to scan the whole sample under 4, and you want to look for things. If it's a voided sample, you've got to be cautious because you can get foreign debris that can mimic casts. But what's really good is to have some really nice posters which are out there on the wall at the microscope, so that when you're scanning at 4x and you look up and you go, oh yeah, okay. And generally, if you have to ask, is this a cast? It's probably not. They stick out at you because once you see them, as you said, oh, that's a cat. Oh, that's a leukocyte cast. Yeah, that's cool. That's why having the methylene blue as well can help bring that contrast to it. But it's really helpful, especially if you're not looking at huge numbers, to have those on the wall next to the microscope or available, ideally so you don't have to page through pages, but so that you can remember what each individual type of cast looks like, so that when you do come across it, or your technician or your nurse or whoever, then they don't have to spend time looking it up. They can just look at that and go, oh no, that's too irregular, that's too small. And then they're worried, then they can come and signal to you and say, hey, can you just come look at this? I'm just a little bit worried, it's a cast. And that's a great collaboration, because then you can both agree or disagree on it. So it's the same thing with a lot of epithelial cells or anything like that, where you're looking at them and having those reference pictures. People remember pictures. They remember pictures in color and things like that a lot better.
My take with casts, or my understanding of them, is like, okay, it's fine if you got white cells, right? And they're big, like basically tubular structures full of bacteria and white cells, right? Like something like a pyelonephritis or something. But if you got like some kind of kidney damage and the epithelial cells of the tubules or something are starting to slough off, like my thought was it was a spectrum. Like the more cellular they are, the more acute the injury is, and the more clear it gets, the more chronic it has. Is there some kind of relationship like that, or not really?
Not really that I could find. And certainly people who look at a lot of, I would say some of a urology specialist would probably have a point of view on that. I think that most people are just lucky to find the casts to decide whether or not your kidney damage is acute or chronic. And in context with biochemistry and acute phase proteins and things like that, you're probably going to have an index of suspicion that whether it's acute or chronic anyway.
Severe azotemia, and you look under the microscope and there's casts everywhere, and you're like, ooh, just a nasty one. But at least it kind of, for me, it means there's kidney involvement if we've got casts.
Absolutely.
So you should see most casts at ×4, and then you can zoom in to kind of see what they're made of. But casts generally tubular structures, shape of a tubule in a sense.
Yeah. Well, sometimes they definitely a tubule structure, but they can have tapered end at times. So I guess some people might look at them in that context as parasites, or broken off bits of something. Like I said, it's a really good idea to have photos or some sort of reference material when you're looking at them, especially if you don't see them very often.
Yeah.
I've looked at a lot of urine cytology, and I've never seen a cast except in a wet prep in a clinical practice. So
Really?
That's one of the good points about doing it in-house, is that you're going to see more casts than I do.
Yeah.
Okay. Let's start wrapping up. One very simple, very, very practical question. I asked about how long between starting antibiotics does it start affecting your culture. Same with the SG. We haven't even really touched on SG. Very often you have these cases and they come in and they're on fluids because the bladder's empty and you can't get your sample until later.
Yeah.
How much can I trust what my SG says once the animal's on fluids? Is it as soon as I put it on a drip, don't trust the SG anymore because the urine that's produced from
I wouldn't say no, it's not as soon as you put it on fluids, but if you can think about in your treatment history, how long does it take for an animal on fluids to pee?
So it kind of depends on the volume, the boluses,
how sick it is.
Yeah, I
all of that.
get urine from dogs who they've been on fluids for 6-7 hours, because if they have an azotemia and then they have concentrated urine still, or like something like 1030, then and they've been on fluids and I've given a couple boluses, then I know that urine was concentrated to begin with.
Yeah.
And
exactly.
Yeah.
It's a matter of being in context. I mean, and you can, most of the time when they give you reference intervals for urine specific gravity, they are assuming that it's without any fluid therapy or diuretics.
Okay.
So that's really going to be a clinical call. And I would say that as soon as you could get urine, you should. And these days you can almost scan it with your phone with an ultrasound. Just, as soon as you can is great. But always that interpretation will have to be in context to the clinical situation.
Yeah.
Magnificent. Kristen, you're a legend. Thank you. That was really interesting.
Thank you so much.
Every time we do these, I think, I wonder what I'm going to learn. But every time I learn so much.
I like the cells in the EDTA sample. That was really good. And then the differences between refrigerating and not refrigerating. I think that was pretty good too.
So your colleagues are going to see you walking around with tubes of urine in your pockets?
No, generally, actually, there's syringes of urine against my ear. That's where I warm them up.
You don't have enough hair to keep it warm.
The worst is when you get home and you scrubs and you unpack you get your keys out and you go, why is there a tube of piss in my pocket?